Good afternoon, everybody. I think we're going to get started. My name is Josh Sharfstein. I'm the Vice Dean for Public Health Practice and Community Engagement at the Johns Hopkins Bloomberg School of Public Health, and it's my pleasure to welcome you to the Bloomberg Center for this really interesting and important event called Expanding Methadone Access in Correctional Facilities, an opportunity to save lives and promote equity. As you will hear from today's speakers, we are at a critical moment of opportunity to improve access to a life-saving medication in a setting which can make all the difference between increasing risk for people or helping them take a critically important step on the road to recovery. Today's event is being sponsored by the Johns Hopkins Center for Mental Health and Addiction Policy in partnership with the White House Office of National Drug Control Policy. Before we get underway, I've been instructed to tell you a few things and not to blow it. So I'm going to do my best. Number one, we will leave some time for questions. If you are watching this event online, please enter your questions using the Q&A feature. For those of you not in the room, for those of you in the room, number two, please write questions on the index cards that are being handed out and pass your questions forward. Do we have index cards in here? Yes, okay. Number three, to let you know that materials from today's event will be available online at the Opioids Principles website, which is opioidprinciples.jhsph.edu. That's opioidprinciples.jhsph.edu. There'll be a summary, there'll be some fact sheets, eventually there'll be other materials. And that is it. Those are the three things I had to tell you. So it is now my pleasure to welcome my friend, Dr. Rahul Gupta, the director of the White House Office of National Drug Control Policy. Dr. Gupta has a long track record in public health, having served as a local and state health commissioner in West Virginia. He's a primary care physician, an educator. He led efforts not just on opioids and overdose in West Virginia very well in very difficult circumstances, but also responded to all kinds of different emergency challenges, including environmental disasters. He's the first physician to serve as the White House Director of the Office of National Drug Control Policy, and he has led with evidence and compassion, and it really been remarkable to see the strides that the office and the nation have been able to take under his leadership. He spearheads the Biden-Harris administration's campaign to reduce overdose, improve health, and advance equity. Dr. Gupta, it is my pleasure to welcome you to provide some opening remarks.
Thank you. Good morning, everybody, and I guess it's good afternoon now. Thank you, Dr. Sharfstein, for that introduction, and for thanks to Johns Hopkins University and this Bloomberg School of Public Health for hosting this really important discussion today. Let me just say here, both in the room and those online, it is really great to be with you today to talk about how we, all of us, can make a major difference in a very significant population that often gets forgotten when we discuss the opioid crisis. That's the people behind the walls. I'll start by saying that treatment in carceral settings saves lives, and we need every jail and prison to offer it, every single one. Now, I'll make the case for it, but I know I'm also preaching to the choir. You know, some could say that why should we focus on the population, on this particular population across the nation? We haven't before across administrations. And so why should my office and the Biden-Harris administration care? Well, as Josh mentioned, let me share with numbers why. In 2022, if you look at the final data numbers from CDC, we lost 107,941 Americans through drug overdoses and poisonings. That's a life lost every 5 minutes around the clock. Now, these are not just numbers. These are parents, these are siblings, these are friends, these are loved ones who leave an empty seat at the dinner table each night and a hole in the fabric of our nation. So this crisis is personal to the president, as it is personal to me and to so many of you here today. And that's exactly why this administration has worked and continues to work tirelessly to expand access to treatment, make opioid overdose reversal medications like naloxone more available, build a recovery-ready nation, and prevent today's youth from becoming tomorrow's overdose and poisoning victims. Now, reducing overdose deaths and saving lives is our North Star. Every life is precious and worth saving, every single one. Yet people who are in custody rarely get that attention or treatment that they deserve. If you look at the numbers, with upwards of 63% of the nearly 2 million people in custody across the US jails and prisons every single day with SUD, we've estimated that up to 27,000 of the drug overdose deaths in the United States in 2021 were amongst persons in carceral settings or those recently released. That's 27,000 of a total of about 107,000 deaths. And we have ignored this population for far too long. Now we know that while in custody with SUD, treatment is extremely uneven behind the walls. We know that. What's the result as a result of knowing that? Well, the people who are released from carceral settings become particularly vulnerable in the weeks after re-entering community, with a risk of fatal overdose estimated to be up to 129 times higher. 129 times. Now, we also know that there's additional economic cost to the community for putting people behind walls, particularly for those related to drug user. The average taxpayer cost is upward of $40,000 per person annually. And you know, this cost, if you're in an urban area, balloons to $100,000 nearly, or more than $100,000. So these are all the reasons why it's so important to have this conversation today. Now, we're working to expand access to treatment in all of the 122 federal Bureau of Prison facilities, and yes, there's 122 federal facilities across the country, and helping states use federal Medicaid dollars to treat people before release and set them up for success after reentry through the 1115 reentry waiver. So people can begin treatment while in custody and get a warm handoff to services in the community. Now, so far, I'll tell you, 16 states have applied, 3 have been granted the waiver, California, Washington, and Montana. And I fully expect more to follow soon. And this is a top priority for this administration. And now to the main topic of today's event, the revised methadone rule that SAMHSA recently published. Now, we all know that methadone is an effective treatment for opioid use disorder, and this new rule will help expand treatment even more. You know, for decades, it used to be that unless you had a registration as a opioid treatment provider or OTP, you could not treat people with OUD or opioid use disorder in a jail or a prison. Well, that's no longer the case today. In 2022, DEA allowed correctional facilities that have a registration with the DEA and are licensed by their state as a hospital or clinic to provide methadone to patients who present with other conditions if the clinical staff determines they would benefit from the opioid use disorder treatment. And then now the new rule adds jails and prisons to the definition of long-term care facilities, meaning that they don't have to register as an OTP to provide this treatment. So this is a big deal. And so people receiving methadone treatment who enter a carceral facility that doesn't have an OTP now will be able to continue receiving their treatment, again, as long as they present with another condition. This is, as I said, an important step forward. So many of you and others for years had advocated for this, and we've heard from you. And I'm thrilled to share with you today that this has finally happened. Now, data shows methadone reduces the likelihood of someone that will die from an opioid overdose by at least 50%. At least 50%. So methadone works. And I really want to thank my federal colleagues and partners from SAMHSA and DEA and those at ONDCP and the White House who are here today and who have worked diligently, and all of you that have participated in that work to make this new rule a reality that will save more lives and taxpayer dollars for local communities. Thank you for your hard work. And there's other ways that states are being creative in treating people behind walls. For instance, some states, including Virginia, are using funds from SAMHSA's Office for State Opioid Response Program to support MOUD and other treatments in jails and prisons. So folks, this is great news, and it's going to make a real difference for people. Now you might wonder, how do I know that, right? Because I've seen that. I've seen the treatment in carceral settings, and I know it works. I was just recently at a facility in Fairfax County in Virginia, along with a congressional delegation, to see that. And when I visited Camden County Jail in New Jersey last year, let me tell you a story of a person I met, of all the people that struck me. His name is Freddie Flores, who at the time was 38. Now, when I talked to Freddie, he had been in custody off and on since he was 18, for 20 years, for drug-related offenses. He had been using Percocet for many years, but he was not diagnosed with an opioid use disorder until January 4th of 2021, the day he arrived at Camden County Jail. Because why? Because they screened him right away for STD. And that's what the warden there is leading. And since then, Freddie began getting treatment through the jail. And now when I talk to him, he sees a better future for himself. He says, that, hey, I'm excited to show this off to my two sons, ages 18 and 9, that I'm changed. And he said he's looking forward to a new beginning in recovery. And since I've seen so many like Freddie, looking forward to life, people who've promised themselves that they're never going to go back. And that's the magic of the work that you all do that happens. Because this is about turning what once looked like endings for people into new beginnings, new opportunities, and having fulfilling lives. And in turn, they're going to make our communities stronger. And that's exactly what I like to see in every criminal justice setting across America. And that's exactly what brings us all here today, here in the room and online. People, who are struggling with addiction need help. And for non-violent offenders with addiction, we really strongly support diverting them to treatment so they can get their lives back on track. We actively are sharing our model laws on that with everyone who will listen. Now, to be clear, we're still going after traffickers and their enablers, but we also recognize that too many people with addiction have been given jail time instead of the help that they need. Too many lives have been ruined by inequitable laws on the possession of marijuana, unfair sentencing for disparities, the unfair sentencing disparities for people involved with crack cocaine. And that is exactly why you saw President Biden pardon every American with a federal conviction for simple marijuana use or possession, and direct the Department of Justice to stop enforcing the sentencing disparity between powder and crack cocaine. Making sure we aren't locking people up for having a substance use disorder, and making sure that people get the addiction treatment and job support they need before reentry. These are more than just good policy. They are the right thing to do. They are the smart thing to do. And they'll save lives. They'll make our communities safer and stronger. And eventually they'll empower our economy and our nation. This is something we all have to work together on as we move forward. You know, for decades in this country, we've tried the approach of arrest first for addiction. And that is not only the wrong thing to do, but simply has not worked. And this is why the Biden-Harris administration has invested unprecedented amounts to improve access. We've made life-saving treatments like naloxone available over the counter. We've broken decades-old barriers that got people in the way, like the X waiver. And we're working to break even more barriers that everyone who wants treatment should and must be able to get it. And the work that you are doing to make sure that those who are behind the walls get the treatment they need is going to make a tremendous, tremendous difference for not just individuals and communities or their families, but also for our nation at large. Now, at ONDCP, we've done the math. Josh talked about data-driven. So it's really important to make sure you're putting your effort on policy where numbers are there. And we estimate that if every jail and prison across America offered treatment for OUD, we could save up to 16,000 lives from overdose deaths each year. That's 16,000 people each year returning to their communities, entering recovery, rejoining the workforce, and supporting families and strengthening their communities. 16,000 a year. So this would make a huge difference, perhaps one of the biggest in this epidemic. And that's why it's so important that you are joining this conversation today. Now, as I said, preaching to the choir is easy. And I expect many people here today don't need to be convinced that this is important and these are the right steps. But if you came here today unsure of what you should do, I hope you'll leave energized to make a difference in your prison or jail, or in your work to help correctional facilities offer this life-saving treatment. Every single day, we have a chance to save lives. And this is especially true when it comes to people who are in custody. Making sure we offer treatment to people who need it will help make sure that we don't miss any of these chances. And folks, we can do this. That's the bottom line. This is something that we can do. And working together is how we get it done. So I want you to know that our doors are always going to be open, and we appreciate the partnership, the importance and value of the partnership to improve access to treatment. I'll leave you with a statement that President Biden made during his recent State of the Union earlier this month. He said, "We are the United States of America. There's nothing beyond our capacity when we act together." So folks, this is a time for us to act together. Thank you for having me. Thank you. I think we could probably take a couple of questions, I'm told.
A quick question. How much does it cost for a state to be able to participate in this and have the resources available to treat? How much does it normally cost per state, or is there a voucher?
Well, I know it's going to vary, but I could tell you my example for when I visited state of Maine, and you have some experts and who've been very intrinsically involved in that. Same thing goes with others too. If you factor in the cost of the treatment not being offered, meaning sometimes the violence that happens, the smuggling that happens, the other cost of hospitalization, others as a result of that. I am aware that the state of Maine was able to do it without additional dollars from the legislature. We also know that, for example, in Fairfax, they utilized very early some of the HIDA funds to have some additional people there to support that. So it's going to vary. But I think what most important thing for me has been is the costs are nothing compared to the cost of the policy of incarceration for SUD and then not getting people the help that they need. Because that cost is not only in the year's life lost, but also economic cost to the community for life of that individual. Thank you. Now, Katie's. Oh, yeah.
Thanks so much for coming to chat with us. It's such a super important topic. I guess my question is more around the actual delivery. So most of the care in carceral settings in the U.S. is contracted out to private contractors. How do you incentivize them to really provide this really important life-saving care?
Thank you. You know, when I was a state commissioner in West Virginia, that's one of the things I realized, that the contractors get a certain number of amount of appropriations per year, and that doesn't really change based on their, as long as they're fulfilling the contract. I think that's the work I talked about we're gonna have to do together, is to find ways to incentivize the contractors or figure out how else to do this to create this opportunity. Whether it's this work right now in jails and prisons, whether it's the 1115 waiver work, I think it's gonna be important to go from a model that's been there for a lot of state-level prisons for contractors to a model that actually is focused on individuals that are behind the wall. So it's a really important question, and I think that's one that we're going to have to grapple with. We try to do everything in West Virginia to incentivize that. Sometimes it's successful, sometimes not, because it's all about dollars and how much resources that go in. So I think the legislature has a role to play. I think the leadership in state offices have a role to play, and then obviously the private sector has a role to play. Thank you.
Dr. Gupta, Peter Katujian, Sheriff of Middlesex County, Massachusetts, and we've been doing medication-assisted treatment in our facility for about 10 years and offering now for the last 5 years all three forms, antagonist and agonist. And I guess for someone that's been doing it for a while, I love the fact that we're trying to expand methadone access. But what about the other forms that really, we've got to meet people where they're at. And so methadone may be your first push because of the difficulty in getting it inside facilities with the OTPs and other regulations that affect facilities. I'm assuming that's why this is this push, and then but the others, the other agonists and antagonists are not lost in this expansion as well, I'm assuming. Correct, sir?
Yes, thank you, Sheriff Katujian. Thank you for your work and your leadership across the nation on this work. It's so critical. You're right. All of the 3 FDA-approved medications are important, and we need to make sure that there's a clinical decision at the end of the day to make that not a decision that are directed through other means. So it has to be a clinical, because ultimately it's a human being on the other side that we have to treat, and that has to according to the criteria and clinical criteria for that. I will say, in our experience, like in my experience when we did this in West Virginia, and we offered one of the ones, naltrexone, it was reviewed, and what was found, there seems to be a common thread also here, which is the loss of the transition of care piece as well. And that's why I think on one hand we have to focus on getting the treatment behind the walls, but also we have to focus on getting an impact on transition of care, because one of the things we found was people were lost when they were given injectable and for 30 days they didn't have to come back. They actually got lost to care. So I think part of this is also ensuring that, and that's where the 1115 waiver comes in, other methods, so we can have continuity of warm handoff and care that becomes so critical. But I do think letting clinicians make that decision and offering all 3 FDA-approved medication and seeing what works for which community and how is critical. Thank you. Thank you so much. Appreciate it.
Thank you so much, Dr. Gupta. I had no idea that the sheriff of Middlesex County was here. I could have used your help calling the meeting to order, I think. I want to just reiterate for people who are watching, they can put questions in the Q&A online. And of course, people here have your index cards. And with that, we're going to turn to our first panel.
Well, thank you, Dr. Gupta, and good afternoon, everyone. My name is Brendan Saloner. I'm a Bloomberg Professor of American Health at the Johns Hopkins Bloomberg School of Public Health. And for our first panel, I'm joined by Matthew Straight from the Drug Enforcement Administration and Yngvild Olsen from the Substance Abuse and Mental Health Services Administration. Mr. Straight has been with the DEA for the past 24 years and currently serves as the Deputy Assistant Administrator in the Diversion Control Division, where his work focuses on the regulation of controlled substances, including their manufacture, distribution, prescribing, and dispensing. Dr. Olsen serves as the Director for the Center for Substance Abuse Treatment at SAMHSA. She's well known for her work in the field of substance use treatment policy and quality improvement, and previously served as the Vice President of the American Society of Addiction Medicine. So we've just heard from Director Gupta about the critical priority to reduce overdose deaths and promote equity. Carceral facilities are a key touch point to increase access to all 3 medications that treat opioid use disorder. But today, we're going to focus on methadone. So I want to start with Matt. Matt, can you talk about how the Drug Enforcement Administration has been supporting efforts to increase methadone access in carceral facilities?
Sure. Thank you. Is that working? Thank you. Yeah, so actually I want to give a shout out to our federal stakeholders, our federal partners at the Substance Abuse and Mental Health Services Administration, specifically Dr. Olsen. I feel like the 2 of us and our respective agencies have been tied at the hip since at least 2021, working on access issues, whether those access issues be in a carceral setting or not a carceral setting. The point is that at DEA, even though we are a federal law enforcement agency with a single mission, we are absolutely all in on ensuring that patients with opioid use disorder have access. And that involves a lot of different efforts to try to prevent burdens or challenges that result from either the Controlled Substances Act or our implementing regulations. And we're doing a lot in that space to try to expand access.
Great. Maybe we can just walk through a few of those options. So we already know that some facilities can become an OTP or an NTP in DEA speak. And we also know that there's successful models of carceral facilities making partnerships with community NTPs and bringing medication on site. But I wonder if we could just pause for a minute and talk a little bit about this new option in the SAMHSA rule. And maybe I'll turn to you, Dr. Olsen, to just expand on what's new in the SAMHSA rule.
Sure, thanks. Okay, yes. Thanks so much, and really just incredible opportunity to be here with all of you, with Director Gupta, with my friend Matt Straight. Matt is correct. We have been working really diligently together on everything from implementing the provisions related to the removal of the buprenorphine waiver, which we're not talking about today, but also improved education of healthcare practitioners to prescribe medications like buprenorphine. But specifically, really on the Part 8 piece, I think one of the things that, and as Director Gupta mentioned, that we know at SAMHSA that the carceral setting and people leaving that setting are at incredibly high risk for overdose. And we also know that medications like methadone, buprenorphine, can reduce that mortality risk by over 50%. And so that was really kind of the impetus, and knowing that we have an incredible overdose crisis, that was the impetus for really taking a look at the Part 8 and seeing how can we make changes in that regulation that really then would help advance access and expand access to individuals. You know, one of the things that I think, because there had been for many, many years, the provision in the Part 8 rule that really identified hospitals as a setting where if individuals had a primary health condition other than an opiate use disorder, other than a substance use disorder, that hospital didn't need to be an opioid treatment program by regulation. If you think about it, to some extent, carceral settings are, while they are not hospitals, they are places where people, they're there. They're there for different periods of time. They may be there, for the most part, they're there not voluntarily, but they are. They often have also complex conditions. It's hard for them to leave that setting to go out into the community and get their medication, get their treatments. And so really the idea of bringing the treatment into the facility makes a lot of sense. And there are different options, as you've mentioned. But there also have been many challenges to those options, and so as a jail, as a prison, where there are also now security considerations, certainly, but also it's a secure location, So I think that part of what we were really thinking about is, could we use that same type of approach for when we're talking about methadone to really help people not only get started on methadone in those settings before they leave the facilities, and then also, as mentioned, really be able to continue those medications so that that we can help reduce that mortality risk.
That's terrific, and maybe you'll indulge me in just a moment of policy nerdery. So we're going to pause on this specific provision of the rule because it's really important. So, and it would be great to get the DEA on record as sort of clarifying, what does this provision actually state?
Sure. So that it's a great question, and obviously under the Controlled Substances Act, we license entities based on a business activity. So under this provision, and again, this is work that we do collaboratively, although I'm not taking credit at all for SAMHSA's amazing work, but this is something that we worked on together. If an entity, if a carceral setting ended up having a registration federally as a hospital or a clinic, what it means is it affords a lot of the opportunities that are afforded to hospitals and clinics to that carceral setting, right? So in the case where that carceral setting is delivering health care, and they're recognized under federal and state law as a hospital or a clinic, it means that some of these same things are afforded to the folks who are operating those systems.
That's great, and I think we're all going to be really excited for the work that lies ahead. We've got a really important task of making sure that the promise that's in this regulation is fulfilled through concrete actions, and I know that the DEA stands ready to help. And I think maybe we could talk for a moment about some of the success that the DEA did have recently expanding methadone treatment in the Federal Bureau of Prisons. So maybe you could comment on that.
Yeah, and obviously the Bureau of Prisons is a federal partner for us. It is a sister agency to within the Department of Justice, and obviously access to those that were incarcerated in a federal prison became of utmost importance to the administration early. And we worked to actually establish a different kind of registration type. Again, knowing that we register by business activity, we license opioid treatment programs, which we, for some strange reason, call narcotic treatment programs. But OTPs, we actually worked to ensure that we had an OTP designation for each of the 97 BOP facilities. We were able to do that in, I believe it was January, February of 2023. We initiated that action pretty quickly. And by doing that, then as an OTP, those BOP facilities then had the rights and authorities that any OTP in the country would have. And we did that for every single location.
Wow. I really want to just make sure that this is, I think this is actually an applause line, and I just want to have it recognized. So you're saying 90 BOP facilities in the span of a few short months got registration as NTPs. I mean, let's give it up for the DEA.
And SAMHSA.
So it was really, that was a very collaborative effort, because they also then have gotten certification from SAMHSA as OTPs. And, I just also want to say that I think that that we are really excited about this provision, that now adds another tool in the toolbox for jails and prisons to think about, and to think about it in the context, I think, of kind of that, the other healthcare practices that they may be implementing, and the other needs that people might have depending on how long they're going to be, in the carceral setting, what else they may be facing, and then what else, kind of in that reentry piece, because that is, I think, the other critical component that is not really, mentioned in any of our regulations, but that reentry piece and back into the community. And so developing those partnerships in the community is going to also be incredibly important, as you mentioned, as we move forward in really implementing some of this. So
the promise of what we can do when people are incarcerated is only going to be fulfilled if we can keep them on medication after they've been released. And Dr. Olsen, maybe we could stick with you just to have you expand a little bit about what SAMHSA does to support these different phases of work, from screening, intake, starting people on medication if that's what they need, and then keeping them on medication in the community.
Yeah. So there are a couple of different pieces that SAMHSA has been funding. We also know that we have lots of other partners and other entities, organizations, professional organizations that are really interested in this as well, helping, because I think, part of this is also helping provide some guidance. So particularly around the primary condition that is also going to be part of this, new opportunity. So really defining what does that primary condition kind of look like, and that's something that we're working with our colleagues at DEA on, really helping to clarify exactly that for the field, as well as provide resources, training resources for clinicians, for others, for the correctional officers, kind of who are now going to be, really thinking about this option. And I think, in the next panel, I'm imagining we'll kind of hear a little bit about that. But SAMHSA funds a number of different training and technical assistance programs. So one is the provider clinical support system that provides a whole host of web trainings, webinars, both synchronous, asynchronous mentorship platforms. We also have an addiction technology transfer center and an opioid response network that really provides individualized technical assistance across a whole different set of sectors that is also really a tangible resource. And so I think there's going to be more, obviously, as we really also hear from the field as to what else is needed as they're looking at this, but those are just kind of a few things. Right. I wanted to mention also, in 2019, SAMHSA did develop a kind of a toolkit, a tool guide for thinking about medications for opioid disorder in correctional settings that now we're going to have to update. So clearly, really being able to, kind of update that and provide some additional resources. So
that's a good problem to have, because it means that the options themselves are changing. And I guess the message is watch this space. There's going to be a lot of great implementation work coming from both of these agencies that work so well together. So great, thank you for that. I'm going to kick it over to Sarah.
Thank you so much, Brendan, and thank you, Matt and Dr. Olsen. It's really exciting and encouraging to hear that this is a commitment of our federal partners. So I'm going to skip my introduction because we're short on time and just kick it right over to our panelists. I'm joined today by Dr. Catherine Smith from the Washington State Department of Corrections and Dr. Ryan Thornell, the director of the Arizona Department of Corrections, Rehabilitation, and Reentry. And like we talked about, this panel is specifically going to focus on medication for the treatment of opioid use disorder, and specifically methadone, and what that provision looks like in practice in carceral settings. So, Dr. Smith, I'd love to start with you. You're the first physician in the country to use the hospital clinic designation that was discussed in the first panel to treat patients with opioid use disorder using methadone. Can you tell us a little bit about your experience using the hospital clinic pathway?
Yeah, thank you, Sarah. So I first wanted to kind of bring up why is it important to have methadone in a carceral setting, especially when there's other options available. And methadone, it's nothing noble or radical that we're trying to do here. It's literally just trying to take a standard of care that's available in the community, an evidence-based treatment that we're able to offer our patients in the community and bring that care into a prison or jail setting. So just providing whatever standard of care I'm able to offer anywhere else inside my setting as well. And we talked about methadone induction or starting people on treatment, but I wanted to highlight methadone discontinuation when we're not able to offer it in our facilities. So these are people that come into our facilities already on methadone, stable in their recovery and doing well. And prior to being able to offer this pathway, we had to essentially taper people off their medications or take them off their treatment that they were stable on prior to arrival in our setting. So this is folks that to bring it to the patient level, these are folks that literally cry to me and tell me that this is the first time they've ever felt stable in their life. This is the medication that saved their life, things like that, and they're begging me to continue it, and I was legally obligated to discontinue their treatment and take them basically from a place of being stable in their recovery in a setting now that's probably one of the most stressful in their life, and then destabilizing their treatment, essentially. So that's why it was really important for me to be able to bring methadone into our system. And by the time we came around to exploring this pathway that we're talking about here, I had already for multiple years been trying the other methods that we touched on. So I had tried to partner with 4 or 5 different OTPs in my community across the state. We also explored the option of becoming an OTP. When you're a jail, it could be a little bit different, but a large prison system that has multiple facilities and a lot of administrative and bureaucratic burden anyways, I wasn't excited about taking on the administrative burden of becoming an OTP and carrying that myself. So it was really instrumental to have my partnership with the Washington State Opioid Treatment Authority, the Washington SOTA. She knew already of the struggles of bringing methadone into our system, and so she brought up this pathway when the white paper from Johns Hopkins came out, and she really brought it to our attention, along with the Medicaid director in Washington State. So they brought up this option as an option for us. We explored it. I talked with my leadership and also with my director of pharmacy, who's very particular about rules and regulations. So he was definitely a part of the discussion. And I was already familiar with the hospital clinic pathway. I worked in multiple inpatient settings in hospitals in which we were able to start people on treatment who were under our care for other things. And then we were also set up pretty perfectly in our system to be able to use this pathway. So Washington State DOC is entirely state funded and state employed. So we don't have a partnership or a contracted medical entity that works with us or a contracted pharmacy. We're all Washington State employed. So we had a centralized pharmacy already that provides medications in our system, which means we already had protocols, procedures in place for providing controlled substances, dispensing, storage, everything in our system already. And we already had a DEA license for each of our facilities separately, designated as a hospital clinic. So we literally didn't have to do anything new to make this happen, which was really nice for me. And then we also, it's noted that we have a fairly complex, a medically complex patient population. So it's often people that we see that have not been touched by any other faction of the healthcare system, and they come into our system having not had any other care. So we're never short of a primary diagnosis in order to be able to treat their underlying SUD issues as well. And then I just wanted to give a shout out to Johns Hopkins. They really helped me out with with pursuing this pathway. They helped create the letter that I sent to the DEA along with my Washington soda. And then I adjusted it to fit my setting. I ran it by the Washington Attorney General. He said it was a pretty solid plan as long as I documented appropriately, which I always do. And so I submitted the letter essentially informing the DEA that as of a certain date, we would be pursuing this pathway to continue people on methadone. And so that's what we did. And my first patient, on the very first day we were going to implement, I arrived, I had a patient in our system on methadone. He was stable at his dose. We were able to continue him, and his inspiration for his recovery is his infant daughter. So he's really doing well and has continued on his medication, has been really grateful to us for pursuing this for him.
Thank you. That's so powerful, and thank you for being the first and being brave and taking that risk with us. Director Thornell, you've been a longtime advocate for medication for the treatment of opioid use disorder in the facilities you've overseen, and you've gained national recognition for implementing best practices when you were Deputy Commissioner in Maine. Can you tell us a little bit about your experience implementing MOUD and kind of share how the hospital clinic pathway might be useful?
Well, thank you. I think for me, it's important to first start off by, acknowledging the data, the numbers that Dr. Gupta mentioned in terms of what works here and why it works. And then I want to parallel that with, the work that Sheriff Katusian mentioned in his comments, his question earlier, the work we did in Maine, the work that's happening in Washington and now in Arizona. We know we're able to do this in a correctional setting, in a jail setting, in a prison setting. And so it's important to really stress that in a conversation like this, because the policies are coming and catching up in a way that allows us to do it in a much more comprehensive manner. And we know we really have an obligation, a responsibility to do it in order to save those lives that Dr. Gupta mentioned in his opening comments. I think that as a correctional leader, it's important that when we explore things like the hospital clinic pathway or even the partnerships with community OTPs, as we're trying to bring methadone in, that we also recognize that there's a safety and security aspect to it. And we often, as correctional practitioners outside of the healthcare field, like to put those safety and security concerns up as roadblocks. And really what we need to do is start challenging ourselves as the DEA, as SAMHSA, and as others are breaking down their roadblocks, their bureaucratic roadblocks that Dr. Smith mentioned. We also need to really remove the roadblocks that we put in place because we've been able to demonstrate that we can safely administer methadone as well as every other type of medication in a correctional setting. We can safely and securely store it and partner with release processes to move people into the community. But the other thing that I want to mention, in my experience in doing this, not only in a small state like Maine, but now in a much larger state with a much different correctional population in Arizona, is that it's very consistent across the country that we need to do much more to educate and inform our staff and our communities in why we're doing this, the importance of doing this, and how it releases people, gives them a pathway back into our communities, like Dr. Olsen mentioned, to have a much more sustainable outcome. And what I found to be really effective in doing that is sharing that message with our correctional practitioners on the front lines, because they're some of the ones that we've kept out of the information sharing realm. They don't necessarily know why methadone is important to have as a treatment option, as a healthcare treatment option while somebody's incarcerated. And so we really need to help them understand how it stabilizes that behavior, how it helps individuals get access to programming and education in a different way while they're with us, and then how it sets them up for that success. And so, again, as a practitioner, I think that's the most important message of all of this is as these barriers get removed, these policies evolve and improve, we have to take those steps to do the same practically on the ground.
Any comments? Dr.
Yes,
Smith?
I just wanted to bring up Director Thornell talked about methadone specifically in the setting as opposed to other medication options. And I wanted to bring a clinical perspective on methadone and how it can be helpful as opposed to a different medication like buprenorphine. So there are clinical indications for methadone specifically for different patients. So in the era of OUD with fentanyl, we're seeing patients with incredible opioid tolerances. They've been using fentanyl and now they have tolerance to opioids that's way higher than we ever were seeing with heroin use. And so it's becoming harder to stabilize someone on a medication like buprenorphine. So buprenorphine has a built-in property that basically has a ceiling effect. Once you get to a certain dose, adding more of it doesn't have any additional benefit. So we're seeing people who far surpass the ceiling effect of buprenorphine with their tolerance levels. So our maximum dose of a medication like buprenorphine can't even bring them out of withdrawal. So having that other option of methadone that can bring them, treat their withdrawal and stabilize them on their medication is really imperative in the current day and age.
That's a really great point. And to kind of close us out, our last question, to tie it all together, I think this community piece of the illicit drug supply, and as we talk about scaling up methadone treatment in corrections, we also, have to think about the access issues that come when folks are released back into the community. Can you talk to us, Director Thornell, about some best practices when thinking about the reentry of patients that are on methadone?
Yeah, and it's critically important in this conversation because we can do all of the work possible inside of a correctional setting, jail or prison, but if the community aspect, the community treatment aspect is not ready and prepared on the receiving end, then it's all for nothing, and it actually could have worse effects. And so it's critically important that you have those conversations, that you develop those partnerships. In a state like Arizona, we're scaling significantly, very quickly, medications for opioid use disorder. Went from 0 to nearly 5,000 individuals in the span of 7 months, which is a radical change inside of our prison system, but it also is resulting in a radical change in our community structure. And so we need to sit down with those treatment agencies, those treatment partners, our Medicaid funders in the community, and others who we release to, in order to make sure continuity of care is established prior to release. I tell all of my correctional friends that you can do everything you want inside of a prison or a jail, but if you mess up the continuity of care aspect of healthcare, of housing, any one of those critical aspects, it's all for nothing. And we really negatively impact public safety if that happens. And so establishing those connections is vitally important. And what we're seeing is, much like I spoke about some of our correctional staff, healthcare staff having to come along in the culture change process, we're also seeing the importance of that in our transitional housing settings in the community. Individuals needing to really understand why this medication is important and why they should be offering it in those settings. And so it's all about education and communication and establishing those partnerships proactively so that you can have the outcomes and the continuity you need upon those releases.
I think we're going to transition to some questions, but I just wanted to pause you on one of those data points. How many patients did you say are now treated in Arizona?
Approximately 5,000.
Starting from basically zero.
From zero.
Oh my gosh. Wow, that's amazing. Let's give that some applause too. All right, I think we have some questions.
So reminding people to please send some questions our way. But the first question is, can we take a moment to discuss the importance of peer support and the effect and impact it has on incarcerated individuals? How do we get more funding for peers and implement peers in every jail and prison setting across the United States?
I'm happy to take that question if I can. Peer support, what we find is it's largely as effective or more effective than some treatment groups, counseling sessions that our clinicians can offer, especially inside of the prison and jail setting. While clinicians have a skill set and a service to deliver, hearing something from a peer, somebody with lived experience, somebody who's traveled that journey successfully, and maybe even had some setbacks that they've learned from, goes a long way. And so we find that a peer support system, some sort of a recovery coach system in a correctional environment, but also in a community corrections environment, a parole or probation supervision environment, can really strengthen that continuity of care and the stability process when somebody's releasing and transitioning back into the community. So I wholeheartedly agree that more emphasis, more focus, and certainly more funding would be helpful in expanding that and scaling that.
And maybe I could just add on the funding piece. There have, I think Director Gupta mentioned that the State Opioid Response Grant Program, there have been some states like Virginia that have used some of those funds to be able to help support that type of workforce in a correctional setting. So that is one avenue. There are other avenues also kind of for some federal funding. There is a limit to what the block grants, the substance use block grant, can help fund, but really, thinking creatively, I think also about where some of the braided kind of type funding pieces may come into play is also, I think, something that may be of interest.
Great. I think we have time for one or two more questions. Go ahead.
I'm Dr. Ruth Potee. I'm the medical director of the Franklin County House of Corrections in Greenfield, Mass. And we've had our full OTP license since 2019, and we want to get rid of it. But my pharmacy's telling me the DEA is not going to let them dispense methadone without going through the OTP 222. So I am begging you, Mr. Waite, a letter needs to come out in writing from the DEA, not 2 years from now or 3 years from now. It needs to come out now to the pharmacies that provide medication to carceral facilities saying it's okay. If they have the right DEA license and they're a clinic or a hospital, you can provide them methadone. So that's my specific ask to you, because for those of us that went through all the labor of becoming an OTP, it's a lot of work to do it. And quite honestly, I'm ready to do what Dr. Smith did and get rid of that and get the medicine the way we get all of our medication. So begging you, asking you, thank you.
So if I am understanding the question correctly, OTP license, you're going to retire, you're going to take on the hospital clinic designation, in which case the hospital clinic will be actually ordering methadone supplies directly, not through your pharmacy, but actually ordering it directly, right, from you. So your pharmacy is telling you, oh yeah, no, DEA is not going to allow you to actually purchase this material. So guidance in that area would be really helpful. Understood. Well, take that back. Thank you.
Matt, I have another DEA question for you. The messaging from DEA's central office appears very clearly in support of these activities and these initiatives, but the message seems to vary greatly among field offices. What are the next steps planned from the DEA to ensure these initiatives and practices are monitored consistently across field offices?
Wow, that's a great question. I would say in my 24 years, this is perhaps one of the biggest challenges I think we observe, and I think it's consistent with any large organization, right, is how does the novel approaches that we're taking, the changes that we're taking, talking about kind of dealing with people that are hard set in their ways of believing in certain areas, how do we change minds? That is, change management is a huge, huge thing, and I can only admit or agree to the fact that it exists within DEA like I imagine it exists in most organizations. And that is something we'll continue to work with our 23 field divisions across the country. Because you're right, if it's one thing to have that messaging coming out of headquarters, it's another thing to have that message being delivered to you all who are dealing with our field components.
So I have a question for Dr. Olsen. Is it true that patients with chronic illnesses like hypertension and diabetes are better able to care for their conditions when their opioid use disorder is under control? Has a second part. If so, can we hope that this new provision can be used not only to help patients get methadone for opioid use disorder, but improve their treatment for these other conditions?
Yeah, no, it's a great question. And I think, Dr. Smith may have some thoughts around here as well. Absolutely. People who have hypertension, diabetes, depression, multitude of various other chronic health conditions, when they have an opiate use disorder, and that is unstable, then it makes it much, much harder for them to really not only engage in treatment for those other health conditions, but it makes it just much more complicated for them to really be able to look at, kind of all of their health conditions and manage those in ways that then can help stabilize those conditions as well. And, when people then have, if they have hypertension and they are going through periods of withdrawal and, swings kind of related to their substance use, that also then complicates their underlying hypertension, for example, right? Because one of the symptoms of withdrawal is their blood pressure goes up, their heart rate goes up, chronic pain increases. So absolutely, I think kind of that this ability to really be able to stabilize their opiate use disorder, we know also from lots of research that then can help people stabilize their overall health conditions. And in the community in particular, and as well as in the carceral setting, it helps reduce emergency department visits, hospital admissions. And so it has it just has like overall tremendous benefits.
So to tag on to that, this provision is really meant for individuals that have other medical conditions as well.
So the way that the CSA, and this is probably kind of something for Matt, right? That the way that the CSA is written currently is that the provision for that hospital/clinic designation is one piece of it, and then the second piece is that people then have to have that primary condition, other than an opiate use disorder, in order for facilities to be able to take advantage of this provision. But as Dr. Smith said, I think you're probably very hard pressed to find people who don't have one of those other primary health conditions that we're then going to be more put forth some guidance that really clearly identifies kind of what then falls into those buckets. So,
and then can I just put a point on that, because obviously Dr. Olsen is referring to a provision of the CSA, right? Which then of course leads to this big concern about, well, it's one thing for Dr. Olsen and SAMHSA to say it, but what's DEA going to say, right? And I want to definitely make sure that the group knows we are a public safety organization. We are not a public health organization. We are not in the business of trying to figure out what those appropriate primary conditions should be that should result in the treatment of MOUD as an incidental adjunct. So, and that's our 21 CFR 130607C. So I defer to Dr. Smith, but the point is I really want to try to allay concerns that somehow the DEA is going to come in and say, absolutely not. Hypertension is certainly not an appropriate primary condition. That is not our lane, and we are really trying hard to stay in our lane. So
I think I can add one more comment here, and that is, and Dr. Olsen, correct me if this is incorrect, but in our population, carceral setting populations have a really high incidence of concurrent mental health disorders along with substance use disorders. So some of my patients might not have hypertension or other conditions, but it's a very good chance that they'll have some sort of mental health condition as well.
And the last question I have is there, and this is really probably both for the DEA and SAMHSA, is there a plan to remove the need for that primary indication?
I would probably say that it's a regulation, so therefore it's always subject to be considered. But what that regulation actually does is it removes the obligation, which is unfortunately statutory, that requires a practitioner, if they're going to be in the business of treating patients with OUD, to have a separate registration. So the idea is that this is the carve out that kind of prevents the requirement of getting an OTP. So while that might sound like a reasonable idea, the alternative might not be palatable. So I would say that it's not necessarily something we're contemplating, but if that is the direction that we feel like as the administration that makes sense, then we certainly could move that way because, again, it's regulatory, not statutory.
And that's really, I think, where the, we don't have any authority kind of within SAMHSA's regulatory structure to be able to do that. So we would then really rely on, our DEA partners. And then to the extent that there is a statutory component to it, I think that then would be the other, kind of need for congressional change, et cetera. But yeah, no, I mean, it certainly is something that I think has come up in that, what happens to individuals, maybe the handful of individuals who don't have either a physical or a mental health condition that would serve as primary.
All right. Well, this has been a hugely informative panel. I'm going to actually end with giving Dr. Smith and Director Thornell the last word. So I'm going to ask you each, just in one sentence, to say what your goals are around methadone provision in the place that you work. What do you hope to see in the next year? And I'll start with you, Dr. Smith.
In the next year, I would hope to bring methadone to a lot more patients than we are currently, and also start doing inductions for patients that come into our system as well.
Great.
And I would just say something similar in that, our goal over the next year is to continue the rapid expansion, with methadone being a key part of that. But I would add on that my additional goal is to continue challenging the rest of the correctional field to really push this direction and to move beyond that fear I talked about earlier, and really just get on board with where this needs to go, where healthcare needs to go in corrections going forward.
All right. Josh, you want to close us off?
Yes. First of all, please join me in thanking this tremendous panel. Also, I want to let everyone know here a little bit of bad news, but some good news. The bad news is the microphones here did not pick up on the Zoom, so people who are on Zoom did not hear. But the good news is we have a very high-quality recording that we're going to be able to make available. So if people get in touch with you and say we couldn't hear things, you could say just check online. That is the opioidprinciples.jhsph.edu, and we did put that in the chat for everybody to know. Please, thank you so much for coming.